Welcome to the second podcast for the missed lecture July 25th, 2017. And as an introduction to this second podcast, just want to reiterate that the number of actual beginning concepts which you are probably are trying to acquire was certainly exceeded in the first podcast and will probably be somewhat exceeded in this podcast too. But I want you to realize that even at the beginning level of residency, and perhaps for some of you with other studies, you should capitalize on all opportunities to become as knowledgeable as you can regarding anesthesia knowledge, and in preparation for your written exams and OSCEs and oral exams and all these things. So without further ado, let's try to cover some basic and somewhat advanced concepts regarding autonomic nervous system and cardiac function. So to start with the basics, using Miller's textbook, Basics of Anesthesia, I think that we can establish that the heart and vascular systems are controlled by the autonomic nervous system. You know this. And the sympathetic and parasympathetic efferents innervate the SA and AV nodes. You know this. Sympathetic nervous system increases heart rate through activation of beta 1 adrenergic receptors. I believe you know this. And finally, at the bottom of the paragraph, the parasympathetic nervous system, through its stimulation, may decrease myocardial contractility slightly, but it has its major effect through decreasing heart rate. So when this lecture was live and with an audience response system, I intended to determine how many of you felt you had studied the autonomic nervous system in medical school, and most likely it would have been 100% or 90%. And moving on from there, the next question would have been to determine whether or not you were familiar with the resting autonomic tone of the heart, and the choices were sympathetic alpha 2, parasympathetic nicotinic beta 1, and the resting tone of the autonomic nervous system affecting the heart is parasympathetic. And parasympathetic receptors are called either A, adrenergic receptors, B, muscarinic receptors, C, are found predominantly in ventricles, D, are stimulated by ephedrine, or E, are responsible for hypertension. The obvious answer is that they are called muscarinic receptors. The rest are just distractors. So I found it interesting in reviewing for this podcast lecture that the parasympathetic nervous system is felt to have an effect on a ventricular contractile force. And this is, not entirely intuitive. Now, when it comes to a more advanced concept, this question was intended to bring out something specific. And the question, as written, negative inotropic or chronotropic effect of vagal stimulation, which is more pronounced during increased adrenergic tone, is called A, reciprocal excitation, B, accentuated antagonism, C, muscarinic saturation, D, beta desensitization, or E, cholinergic crisis. And the answer is accentuated antagonism, and you can find this in this textbook, which I gave you a cover shot in the first podcast. And accentuated antagonism refers to finding that the negative inotropic and chronotropic effects of vagal stimulation are more pronounced when vagal stimulation occurs in the presence of increased adrenergic tone. And unfortunately, this is something that happens to anesthetized patients or patients who are undergoing surgery anyway. There's a high level of sympathetic tone, and if vagal stimulation occurs, it can be accentuated. Again, remaining quite factual and trying to hit the high points here. The neurotransmitter of the peripheral sympathetic nervous system is A, dopamine, B, acetylcholine, C, epinephrine, D, norepinephrine, or E, vasopressin. And the answer is norepinephrine. So within the sympathetic nervous system, the neurotransmitter, which is released from presynaptic vesicles, is norepinephrine, and it is the mediator of increased heart rate and contractility and the lusotropic effects. However, this is not what you see when you give norepinephrine intravenously. Nonetheless, the neurotransmitter of the heart and of the sympathetic nervous system is norepinephrine. And this slide here from Miller's basic anesthesia text reiterates that at rest, the heart has a tonic level of parasympathetic cardiac nerve firing and little, if any, sympathetic activity. Therefore, the major influence on the heart at rest is parasympathetic. This table has a lot of information on it, some of which we've covered to an extent, and some of it is intended to be a practical guide or cheat sheet for the selection of pharmacologic agents, such that if you wanted to increase cardiac output, you would select dopamine or isoproterenol or dobutamine and not norepinephrine, which is slightly paradoxical, considering that I just told you that it is a mediator for contractility. However, that is not the case when administered to patients under normal conditions. There may be special conditions where the norepinephrine has an effect on cardiac output, such as when there's alpha blockade. Nonetheless, this slide is meant to summarize the dominant response on the heart from the sympathetic and parasympathetic point of view, and that is that in fact the rate of contraction and the force of contraction is predominantly controlled by the cholinergic nervous system. And blood vessels, arteries, muscles, veins, etc., under the alpha-1 receptors and beta-2 receptors are under the predominant control of the adrenergic nervous system. Despite the fact that the resting tone of the cardiovascular system is under the control of the parasympathetic nervous system, the physiology and pharmacology, as far as it concerns anesthesia, is primarily sympathetic. At least that's how I view it. So I'm going to proceed into a few more audience response questions without audience response clickers, and this is for a bit of a review. So all these things, some of these will be kind of obvious. Ephedrine. A is located only in the OR pharmacy. B is an anticholinergic drug. C is a direct-acting catecholamine sympathomimetic. D is an indirect-acting sympathomimetic. E is an alpha-2 agonist. The only correct answer here is that it is an indirect acting sympathomimetic, and I define it to be typically used intravenously in doses of 5 to 10 milligrams in adults to achieve an increase in blood pressure in the perioperative period when an increase in contractility or blood pressure is desired by an anesthesiologist. So that's a little bit of a tongue-in-cheek but practical definition of what is ephedrine, and it is kind of mechanical. This is how we use it. We use ephedrine when we want an increase in blood pressure or an increase in heart rate and contractility, because that is how it works. It is a indirect acting sympathomimetic. It's to put it into compare it to dopamine. You could say that ephedrine is dopamine in a syringe. Now, phenylephrine, is it A, located only in the OR pharmacy? B, is it an anticholinergic drug? C, is it a direct-acting catecholamine sympathomimetic? D, is it a direct-acting non-catecholamine sympathomimetic? Or E, is it an alpha-2 agonist? The only correct answer here is that it is a direct-acting non-catecholamine alpha-1 agonist. So, to digress, a catecholamine is any of a group of sympathomimetic compounds composed of a catechol moiety carrying an alkyl side chain with an amine group on the side chain. And that comes from the Mosby's Medical Dictionary. So, one of my interests is the use of glycopyrrolate, and I'm fairly liberal in glycopyrrolate, and there are a number of publications which support the use of glycopyrrolate in various clinical scenarios. And here is a report of an original investigation where prophylactic glycopyrrolate was used and was shown to reduce the hypotensive response in elderly patients during spinal anesthesia. So, in time and with experience, you're going to see a number of predictable and not so predictable responses to laryngoscopy, to pain, to the insertion of nerve blocks, the insertion of epidural injections and catheters, and glycopyrrolate, being an anticholinergic, will tend to minimize or prevent cholinergic reaction. So on this slide, I just want to summarize that that things change over time, and at one time ephedrine was good and phenylephrine was bad in obstetrics, and now it's the reverse. Also the textbook Basics of Anesthesia refers to anticholinergics being used with diethyl ether, which of course is not used at all anymore because of explosive characteristics. Ether stimulated secretions but was a respiratory and cardiovascular stimulant. The use of atropine may have been to prevent vagal reflexes because of accentuated antagonism, but also it apparently did cause a fair bit of salivation because it was a little bit irritant. You should remember that at one point in time, succinylcholine was a very popular neuromuscular blocking agents. Now, Table 7.3 compares 3 anticholinergics as IM premedicants. I doubt that any member of the Department of Anesthesiology at UK uses an IM anticholinergic premedicant anymore, although a neonate may be an exception. You have to think about the effect of extreme bradycardia, such as a heart rate of 50 in a neonate, and how that affects cardiac output. It can be very, very impressive. So, getting back to questions, dopamine, is it A, catecholamine, B, a popular inotropic agent, C, typically prescribed in milligrams per kilogram per hour, D, recommended for peripheral intravenous administration, or E, a weak sympathomimetic? Well, the best answer to this question is that it is a catecholamine. It is not a particularly popular inotropic agent anymore. It is not typically prescribed in milligrams per kilogram per hour, but rather mics per kilo per minute. It has a potential to cause vasoconstriction if it extravasates, and it therefore is not recommended for peripheral intravenous administration, and it is not particularly weak, although it has studies have shown that its pharmacodynamic profile sometimes is too potent on the pulmonary vasculature and not potent enough on cardiac contractility. So it's a catecholamine. Dobutamine A, acts through release of norepinephrine. B, is infrequently prescribed in cardiology practice. C, does not cause tachycardia. D, is prescribed in mics per minute. Or E, is a racemic mixture of D-dobutamine and L-dobutamine. Well, the best answer for this multiple choice question is that it is a racemic mixture of D and L-dobutamine. And by and large, behaves much more like a beta agonist than an alpha agonist. So this is a backwards question. Choose the best incorrect statement. Epinephrine is dosed in mics per minute. B, should never be administered by peripheral vein. D, is dosed in mics per kilo per minute. D, has significant metabolic effects. E, has variable effect on blood pressure dependent on dose. And the best incorrect answer is norepinephrine question is the correct answer is that it's an alpha-1 agonist. All the other ones are kind of distracting and pharmacology would advise against administering norepinephrine with bicarb. So going forward here, the epinephrine question was answered, the norepinephrine question was answered, and we're getting towards the end of the podcast here at about 20 minutes, so mercifully short. And my point here is that you should really look things up yourself. Don't ask a resident or your senior resident or even your attending or even me to get a definitive answer on everything. It's fine to panel your attendings and see what they know, but my experience is that when it comes to pharmacology, it's best to use textbooks and review and look up review articles and think critically and read critically. So I thank you for your attendance and your attention, and hope that you can take a little bit of this introduction to cardiac physiology and autonomic nervous system, and look forward to working with you in the operating room.